Have any Portland? So we don't have anyone from Portland. Everybody's in Corvallis, so that makes sense. Okay. Just let me know when to start. It's 12 o'clock my time. Can I start now or should I wait another few minutes? Okay, it says we are ready to start. The recording is rolling. Thank you so much. I really appreciate it. I know I'm calling from Portland. I will be there on tomorrow. We're going to have 4 hours of lecture, and I will be down in Corvallis, and I'll be more than happy to answer any question. But if there is something urgent and you want to answer, I'll be more than happy to answer your question. Does anybody have a question? You can put them in the chat for me. And the fact is I'm not there doesn't mean you cannot interrupt me. Please feel free to interrupt me and ask me questions. You know, this has to be done. I'm doing this for you, so I know this material very well. So I want to make sure I'm clear about everything we are covering today. So we briefly talked about how the kidney through different hormones control the perfusion. And that's extremely important because if it's very low, it really decreases of the filtration, excretion, reabsorption, and elimination. And very high, it is more susceptible to the vascular toxicities from the high pressures. The two other things I want to make it clear is kidney plays such an important role in production of the erythropoietin. And there is a drug, it's called erythropoietin, or EPO, or some people call them ESA, erythrocyte stimulating agent. And that was the first biological drugs came to the market, and after insulin. And it's a protein, and you can give it IV or sub-Q. It's not orally. There are some oral formulation in development, but it's a sub-Q or IV. We use it a lot for almost every dialysis patients because their kidneys not make the erythropoietin anymore. This is very important for oxygenation. The oxygenation is what you breathe to your lung, but if you don't have red blood cell, you cannot carry it. And the lack of the oxygenation is not just you're not breathing very well, it put the patient at risk for the cardiovascular disease because you can develop high output heart failure. And another one is the calcitrol. Calcitrol is an active form of the vitamin D, and the vitamin D is essential for calcium reabsorption and incorporation of the calcium inside the bone. And as a result of that, this patient can develop a lot of osteomalacia and osteoporosis over time. And we actually give calcitrol to this patient, like erythropoietin, by mouth, and you can give them the IV too, and to help them if they have issues. Think about the erythropoietin and calcitrol like you have insulin for diabetic patient. They are the hormones that they're essential, and you have to use them on patient with chronic kidney disease. Am I clear about that? Good. So now, as we have learned how important renin-angiotensin system is and how it regulates amount of the sodium eliminated in the urine, and how the atrial natriuretic peptide counter affect the renin-angiotensin system, you can really understand with manipulating, one more time, with manipulating these two major systems, you can have beneficial effect, not only in the kidney, you can have in cardiovascular. If you remember, I started my lecture is relationship between the kidney and the heart. The kidney really great. Now, some people say heart control the kidney. Some people say kidney control the heart. The bottom line is they work together. They work together to provide the hemostasis and the blood pressures and perfusions and make sure everything has in the natural processes. And we have ADH and vasopressin. Now, ADH and vasopressin, they control amount of the water in the urine. And we do have drugs that can affect the ADH and vasopressin, but my gosh, they're so potent that I am not exaggerating. People who take these vasopressin antagonists, they pee. They literally pee in their pants and after taking the medicine because they lose their ability to control water excretion. You just lose water like crazy, which sounds very good because you think about it as a diuretic. We don't call them diuretic, we call them aquaretic. One more time, not a diuretic, aquaretic. And we sometimes use them on patients with the heart failure because they're not responding to diuretic anymore. At that time, we go to the aquaretic treatment for those individual patients. So aldosterone is extremely important. Aldosterone is extremely important part of this RAS system, renin, angiotensin, aldosterone pathway. We call them RAS system. And the way aldosterone respond is usually respond to when those macula densa cannot feel or they does not feel the pressures or perfusion, that's a better term, or when there is a low amount of the sodium or your total body volume is low, the aldosterone kick in. What is the function of aldosterone? Well, aldosterone to some extent control the renin, so that way cause the vasoconstriction. And you can say renin, one more time, aldosterone affect the renin and renin affect the aldosterone. So they work together to make sure you increase the pressures. And so angiotensin has a vasopressitory effect and aldosterone cause sodium retention. Guess what? When you have sodium retention, what's going to happen to the water? You will have water retention. When sodiums go up, the waters go up, what's going to happen to the blood pressure? It's going to go up. So that's the way aldosterone. But another thing about the aldosterone is very important. Aldosterone causes fibrosis. Does anybody know what is fibrosis is? Can somebody type it on the chat? When we say it causes fibrosis, what does it mean? Okay, I save you time. Fibrosis is mean it causes connective tissue. Connective tissue is not live tissue. Connective tissue have no function. So you're replacing normal healthy tissue with connective tissues. So think about it. Instead of having myocardium or you have nephron, you have a sclerosing and you will have fibrosis in those tissues. As a result of that, both functions go down significantly, both the cardiac and the renal. And you can say brain or any other part of the body because it's a proliferative agent. It increase amount of the fibrosis. So for that reason, it's very important to inhibit the aldosterone too in these individual patients. So if you look at the urine, this is in the urine, look at urinary, this is urinary, this is urinary. When I talk about blood, that will be opposite. When I said blood, it will be opposite. When I'm talking about the urine, it would be opposite of the blood. So if I give somebody aldosterone, what you should see, what you should expect to see? Well, decrease urinary sodium. decrease urine. With another hand is increasing plasma sodium. Increasing plasma sodium. If you're decreasing sodium urine excretion, what's going to happen to your water? You're decreasing water excretions. So aldosterone causes sodium retention. Aldosterone causes water retention. Are you following me? In here, it shows the urinary, but what would be in the blood? It would be opposite. So your sodiums go up, your water. So aldosterone causes ballooning. The patients start balloon. They will develop edema. Go back and look at the first two cases. Both patients were very edematous because of aldosterone, because of renin, because of angiotensins. And it sounds a good idea. It sounds a good idea. It's a compensatory mechanism, but long-term is harmful for the kidney. So we talked about sodium, we talked about water, we talked about chloride. We said chloride, water, sodium, they follow the same pattern. Wow, look at in here. The urinary for sodium, chloride, and waters go down, the plasma levels go up. And look at the effect on the potassium. Look at the effect of that. Actually, it increased potassium excretion. Now, potassium, too much of it is very harmful. Too little is harmful too. It's the hemostasis of it. And potassium is one of those electrolyte that is mostly intracellular. So what you see is not a very good representation how much patient has. By the time it's way up, it's been you have excessive amount. By the time it's very low, it's been excessively is low. So you have to really look at those numbers with the very carefully that when you're assessing the electrolyte abnormality on patient with chronic kidney disease. So the effect of aldosterone, your plasma potassiums go down, your sodiums go up, your water retentions go up, and of course your chloride go up. That can cause acidosis. So aldosterone, any way you look at it, long-term is harmful. Now, I know you said, Doctor, oh, didn't you say aldosterone is essential? Yes, it's essential. But when you have excess of it, that's harmful. So how the aldosterone control it? Well, aldosterone is called aldosterone receptor or mineralocorticoid receptor. Either way is fine. It binds to this mineralocorticoid receptor or aldosterone receptor. It increases amount of the ENaC expression. And what the ENaC does, it increases sodium retention. It increases sodium retention. It increase chloride retention. So you will have more sodium, you will have more chloride in there. And water follows sodium, water follows the chloride. As a result of that, you end up having more volume and you will have more sodium, and that increases the pressure even further. Now, there are drugs called aldosterone antagonists, such as spironolactone, such as phenynerone. They do opposite. Actually, they decrease sodium reabsorption. As a result of that, it will help with the edema. The only thing about it, you have to watch it, it can cause hyperkalemia and sexual dysfunction. In fact, between all the drugs that you will learn on cardiovascular, probably is the worst. It can cause gynecomastia. It can cause, because it really decreased the testosterone productions. And the last thing is sometimes it can cause the risk of the acidosis because of the amount of the chloride effect that it has sometimes. But the bottom line is when you're inhibiting these receptors, and we do have diuretic, they have a diuretic effect. We use them all the time. You can increase risk of the hyperkalemia on these individual patients. So this is the aldosterone pathway. I maybe I forgot. Did we talk about this slide? Did we talk about this slide? Maybe I skipped one or two slides. Did we talk about this slide? I know I did not. I don't think I went through this slide because this is a very important slide that I apologize, I forgot to say it. So this is when all the hormones are interacting with each other. This is when all the hormones are interacting with each other. This is very important. Now, this is a patient who has a heart failure. A patient who has a heart failure, they're not perfusing very well. When they're not perfusing, the first line of defense is your sympathetic tone. You increase your sympathetic activity. You release epinephrine and norepinephrine. They bind to the alpha receptor to increase the blood pressure. They bind to the beta-1 receptor to increase the contractility and to some extent the chronotropy effect on the heart. And you end up getting vasoconstriction. In addition of these vasoconstriction, you increase of the renin-angiotensin system, you increase release of vasopressin, which is the ADH or called the volume retention. And as a result of this lack of perfusion, you end up increasing the heart rate and contractility. Guess what? The heart is working harder. Now, with the increase of activity of renin, you increasing the blood pressure, you increase amount of aldosterone. What did I tell you about aldosterone? Aldosterone causes hypertrophy. It causes fibrosis. It changed the normal. You remember I talked about the shape of the heart. It changed from a football to a basketball. It become big. Doesn't mean it's working better. In fact, it cannot squeeze anymore. So it does not work better. And you really increase amount of the fibrosis. Now, what was the counter effect? Well, we have natriuretic peptide. We said natriuretic peptide has exactly opposite effect as RAS system and the sympathetic tone. Look at here. This is all the up way. This is a down way arrows. So in here, you're increasing the blood pressure. When the pressure on atriums go up, with release of natriuretic peptide, you decrease the blood pressure. You decrease sympathetic tone. You decrease vasopressin. You decrease aldosterone. You decrease fibrosis and hypertrophy of the heart. So it does have an opposite effect. But all these hormones are controlled by the kidney. Yes, the atrium and the NP, the natriuretic peptides, are to some extent started from the atrium, but mostly they work to decrease the functions of the lot of hormones that come from the kidneys. And you will learn about Entresto, or maybe you already know about Entresto. Entresto has really revolutionized management of the heart failure. And valsartan, which is the ARBs or angiotensin receptor antagonist, has revolutionized management of the chronic kidney disease, because combinations very helpful for the kidney and big time beneficial on the heart, because you stop this remodeling. What is remodeling? Well, when you have that heart, you're changing the structure of the heart and become more fibrotic. You're changing the structures and the model of the heart. From that football shape, you're making it more like a basketball. You're changing the structure. You call it ventricular remodeling. So giving a drug that increases natriuretic peptide, that's naproxen, and a naproxen inhibitor, sacubitril, or give them some drug that inhibit the angiotensin 2 receptor, that would be valsartan. That's a combination drug we call Entresto. It's so beneficial for patients who have a heart failure. The only bad thing is they do decrease the blood pressure. Some patients cannot tolerate it, but it works against all these compensatory mechanisms that we have, and as a result of that, you stop this remodeling of the heart, hypertrophy, and fibrosis on those individual patients. So I apologize, I skipped these two slides. Those are very important slides. I really want you to know how those scenario work. So let's back to our aldosterone and aldosterone antagonists. Aldosterone cause water retention, antagonists decrease water retention. Aldosterone cause water retention and sodium, an increase of potassium excretion, increase of the magnesium excretion. You will have opposite effect. And you remember one of our patients has potassium of the 6. One of our patients has potassium of the 6. And so sometimes if we use those drugs in a patient who have already high potassium, you actually make it worse. In fact, one of the major contraindication for use of aldosterone antagonists is patients who have hyperkalemia, or they cannot tolerate the aldosterone antagonists on those individuals. But the bottom line is the beauty of the aldosterone antagonist is decreasing amount of fibrosis and make sure you decreasing amount of the collagen deposit on those tissues. There are 3 of them in the market. Spironolactone, that most of you guys know about that, but we'll talk about it. Plerrenone, and the best one is phenylalanine. I will say 9 out of 10 I use a spironolactone, 1 out of 10 I use a plerrenone, and I never use phenylalanine, although it is the best between all of them. Well, this costs a penny, this one costs maybe a dime, and this one costs $700-800 per month. So for that reason, I don't even consider use of the phenylalanine. Even therapeutically is better. It is better drug, but because of the cost issue, we don't even consider use of the phenylalanine over plerrenone and spironolactone. And another benefit of phenylalanine compared to the other 2 drugs, it causes significantly less hyperkalemia, and it causes significantly less amount of sexual dysfunction. But as I said, my patients cannot afford this medicine, so we never consider use of the phenylalanine in the clinical setting. It is out there, and probably some of you guys have dispensed it to your patients in your pharmacies. Another class of drugs are flozins or gliflozins or SGLT2 inhibitor, anything you want to call them. They call them sodium glucose transport 2 inhibitors. There has been such a miracle drug for treatment of kidney disease and heart failure and obesity and hyperkalemia and gout. And I can go on benefit of this class of drugs. And I call them statins of 2020 because they have so much benefit short-term and long-term. And one of their benefit is actually you inhibit glucose reabsorption. With inhibiting the glucose reabsorption, you increase, one more time, you increase glucose eliminations. And what is glucose? Calorie. What is calories? You know, it's weight gain. So a good amount of the weight loss you will lose. In addition, because it's a co-transport, sodium glucose co-transport system, to some extent you lose some of the sodium. As a result of that, you lose water. With losing the water, it has a diuretic effect. And so some of the potassiums go with it. So it makes sure the patient does not develop hyperkalemia. On top of that, it really decreases of the glomerular pressure. When a patient has a chronic kidney disease, the problem is in here, that auto-regulation is gone. With decreasing this glomerular pressure, it slows down the injury to the kidney. So it's very beneficial for diabetic with chronic kidney disease. And I will go farther to say, doesn't matter you're diabetic or not diabetic. This drug is beneficial for heart failure and the patient who have chronic kidney disease. I know you all know this class of drug as a diabetic drug, but we call them renal protective agent. As much as you call the ACE inhibitor as a drug for blood pressure, we call them renal protective agents because the way they work and it slow down the fibrosis in the kidneys. So we do have tools now. We do have drug that decreases sympathetic tone. That would be your beta blocker. We have a drug that inhibit the RAS system. That would be your ACE inhibitor, angiotensin converting enzyme inhibitors. And you have the ARBs. They bind to the receptors and it prevent that the angiotensin to bind to the receptors. We do have aldosterone inhibitors that they really slow down the fibrosis in the kidneys. And we have SGL2 inhibitor. They're not only renal protective, they're cardioprotective, they're good for the diabetic. And what was the leading cause of the kidney disease in the United States? It was diabetes. Is beneficial on those patients too. So you can see really how this drug would be beneficial long-term for many, many patients. In fact, as you will learn next year or maybe even this year, that pretty much this is a drug of the choice now as a first-line therapy for a lot of heart failure patients, plus Entresto. Those are the drugs that we use a lot. They are expensive. Hopefully they will be generic, but we don't hesitate to use this drug. It's not like a phenylalanine that is so expensive. I cannot afford it for our patient, but this class, most insurance pay for it because long-term, they're so beneficial for the patients and they have nice benefit. And there are a number of the study have shown not only they help with the kidney, not only they help with the hospitalization, not only they have renal protections. And do you see this? That's 50% reduction. This is 30% reduction. This is 40% reduction with using a different form of the SGL2 inhibitor when it's come to the kidney functions. They have mortality benefit. They have heart failure benefit. They have all-cause death mortality benefit. So any way you look at it, this class, please don't memorize the number. Please do not memorize the number. But I want you to know why we use SGL2 inhibitor on patient with kidney disease, why we use them for heart failure patient, why we use them for patient with cardiovascular, because they're beneficial. They bring the blood pressure down. They have weight benefit. They have hyperkalemia benefit. They have, the diuretic effect. They have normalizing the blood sugar effect. So any way you look at it, they are very beneficial long-term. And now with manipulation of the hormones by these drugs, you can really improve the outcome of the individual patient long-term. And the last one is the ADH. And ADH is very interesting. Of course, it's under control of the renin-angiotensin system, but by itself has the ability to recognize. It has the baroreceptors and osmoreceptors. Baroreceptor work based off the pressure. Osmoreceptor is based off amount of the sodium, and it can sense it, that how much is the osmolality has gone up, I need to hold more volume. So it send a message to the kidney, hey, act as an anti-diuretic hormone, ADH, anti-diuretic hormone. What does it mean? When we say diuretic, we lose sodium, we lose water. Anti-diuretic hormone hold on water, hold on sodium. So the ADH or vasopressin is stimulate in the kidney to recaptures a lot of water lost and when it's going through reabsorption, and in addition, it increases sodium. As a result of that, you're increasing amount of the water. So this is a very nice graphic presentation. The way it works, it increased the number of aquaporin. Aquaporin. Remember, what did I call it? If you're inhibiting the vasopressin, we call them aquaretic. Aqua mean water in Spanish. In aquaretic, so basically you're inhibiting the effect of the water. And the way they work is by giving those molecules, such as conivaptan or tolvaptan, you have aquaretic properties. With increasing the number of the aquaretic, you're decreasing amount of the vasopressin, so you lose a lot of water long term. But the problem is you lose too much water. You lose too much water. So you really have to be careful to use of the aquaretic over diuretic. I would say out of 100 patients you treat, 99.5 of them you use diuretic. There's a 0.5 that you would consider achroretic if they have shown no benefit from the diuretic. But you have to really watch them because they're very potent, and you truly lose water. You truly, all the diuretic is always interaction with the sodium. In here, you lose water. There are some diseases we use this drug. You know, the patient who have cancer, for example, they have excessive amount of the ADH release. For those patients, we actually use achroretic because it inhibits the effect of vasopressin and ADH. So that's the way they work, and they're very important. We use them for heart failure that, as I said, they're not responding to anything. Which hormone play a role in water reabsorption in collective duct tubes? Aldosterone, thyroxine, antidiuretic hormone, corticotropin releasing hormones. Which hormone play a role in water reabsorption? Anybody want to take a shot at that? You can type it in there. It's antidiuretic hormone, right? It's antidiuretic hormone. And I know what you're saying. What aldosterone is effect on the sodium, and sodium have a indirect effect, but this is direct effect. I would say the correct answer in here would be antidiuretic hormone, would be the most important. It really increase amount of the reabsorption of the water in the kidneys. And we talked about those already. So for these lectures, I really want you to know the effect of the major hormones. I want you to know what is ADHS, antidiuretic hormones. What it does is effect is it increase basically water retentions. With increasing the water retention, you increase the plasma, you increase the way it work mostly on the V2 receptors. And drugs such as conivaptan and tolvaptan are ADH antagonists and can be used as a achroretic to increase the free water lost. We have aldosterone, PTH, don't worry about it for now. We have aldosterone, that's a very important hormone. Its mostly effect is by, they get activated by RAS system, and or it can sense it too, by the way. So it has both pathways. When the pressure is low or when you have blood volume is low, it will sense it, and aldosterone cause sodium retention. As a result of that, you get water retention, and to some extent you get chloride retention, but you end up losing potassium on those individual patients who have a very high aldosterone. And there is actually a disease called hyperaldosteronemia because they have a tumor in their adrenal gland, and those patients have extremely high blood pressure, and because it just release so much of the aldosterone, cause all the water retention and increase their blood pressure. So now ANP is opposite. That stretch, that pressure in atrial cause release of the ANPs, and the nice thing about ANP is actually increase GFR. It increased GFR, and it decreased reabsorption of the sodium. With decreasing reabsorption of the sodium, you're decreasing the water retention. So it's very helpful and we do have a drug, you know, the enzyme is called naprolysin, and we have drug that inhibit the naprolysin breakdown. And the last one is angiotensin. Angiotensin 1 convert to the angiotensin 2, and we have angiotensin converting enzyme inhibitor, the ACE inhibitor, that you can block that pathway. Angiotensin 2 physiologically respond to the low blood pressure or low volume, but it binding to angiotensin 2, it increases the blood pressure, but at the same time, it can affect the ADH, it affect the aldosterone, And as a result of that, long term, it's very harmful for the kidney. So with all the drug that we have, and you will learn during this term, you should feel comfortable how this drug work and how they interact with each of those receptors, and how you can manipulate each of those hormones and the respond therapies. Do you guys have any question? You have a microphone over there. Does anybody have any question? So for the first two lecture, or actually three lecture, I really want you to know the anatomy. I want you to know the physiology of the how the perfusion is happening. And most important, I want you to know the hormones. And you're a pharmacist, you should know what drug affect which hormones. Those are the main thing that I really want you to know from the first three lectures. If you know those one, you should be fine for your final exam. But of course, you're not final exam, your first exam, but mostly application, not just memorization. A lot of application of those. Let's do few cases. A patient with chronic kidney disease was admitted with hemoglobin of 7 and hematocrit of 21. The relationship between hemoglobin and hematocrit is 1:3. So that tells me that's correct, because sometimes the patient is well hydrated and those numbers can be low. Hemoglobin really tell you the overall stage of anemia of the patient with chronic kidney. What is the cause of anemia seen in this patient? Does anybody want to answer this question? Can you put them on your chat? Who is our tech officer? Is our tech officer is here? Can she get to the chat and answer that question, the consensus from your class? Or maybe Madeline can do it for us. Okay, somebody's walking over there. So a patient with chronic kidney disease has a hemoglobin of 7 and hematocrit. What's the cause of anemia in this patient? What's the correct answer? Just put them in the chat. What's the consensus in the room? Decreased erythropoietin production, excessive sequestration of red blood cell in the spleen, vitamin D deficiency, red cell membranopathy, deficient in globin synthesis. And you're totally correct. The decreased erythropoietin production is the reason for this patient. Those patients have low hemoglobin and hematocrit. Now, I can say the same question, I can ask a different way. I can ask you, a patient have a hemoglobin of 8 and hematocrit of 24. What is the treatment of the choice for patient? You should be able to say is giving the patient erythropoietin. That would be the method of the choice. Of course, you have to make sure they have enough iron before you do it. A marathon runner drink a large quantity of electrolyte solution with expectation to improve performance during the race. Elevation of what electrolyte in his urine responsible to change tuberoglomerular feedback? Chloride, glucose, magnesium, potassium, urea. Very good. Do you have the answer? I did not expect anybody knows the answer for this one. Very good. Yeah, sodium and chloride. Remember, sodium chloride. That's the best mechanism, the feedback system. So yeah, definitely A is the correct answer. Chloride is the correct answer in there. Very good. Oh, you did have an answer. I forgot. I put the teaching point for you guys in there too. So you do have the answer for all this stuff. Okay, forget about it. Do you guys have any question? Go through all those questions. Go through all those questions. So prepare yourself. Every MCQ that I present in the classroom, that's fair to be in your exam. Those are all fair. It's a fair game. So you should know all those and make sure that you know each of those multiple choice question I'm asking you in the classroom, because I'm trying to give you a point. Now, I will not ask you the identical question, but I will change it. It's the same concept. You know, every lecture has 10 or 15 point, and I have put all those points on different MCQ question. I can't change it. You know, this is what it is. So you should be able to answer those questions. And I know Madeline has put a bunch of great questions for you guys too, that she will cover them on Friday to make sure you'll be able to answer any of those questions. Any questions? Well, I'm coming back tomorrow and we're going to start diuretic. So be prepared for diuretic. And we have 4 hours of lecture tomorrow, 2 hours from 12 to 2, and we have another 2 hours from 4 to 6 p.m. Any questions about that? Thank you so much. See you guys tomorrow.